Hello, everyone. So my name is Archie. I'm a new graduate fellow at UMS. So today I'm going to present two lectures for you. Firstly, I want to let you know that I'm currently working in the UA hospital. The Wi-Fi signal here is really bad, so I cannot use my laptop to connect their internet. Therefore, I pre-record this video for you in order to give you a good presentation without any interruptions. I hope you can understand it. And also, there's no microphone on my desktop here. So if you have any questions, please just type into the chat box so I can type the answer and um, and tap the answer into the chat box as well. So yeah, so hope you can understand that. And okay, let's get started. So the first topic is about mistreatment. So in this topic, our objective is to be able to identify different forms of older adult mistreatment, and also we should know how to perform a history and physical assessment when we were suspicious of mistreatment, and also we should be able to recognize the key signs, symptoms of different types of mistreatment, and also we should know how to ask for help from other healthcare professionals, government, or the courts. So here are all of the sections we covered in this topic. So we will talk about details in each of them later. In terms of definition of elder mistreatment, actually there's no standard definition. So that's one proposed by 2014 Elder Justice Roadmap mentioned all different types of mistreatment in this one paragraph, and so we all talk about those different types for details later. So the first type of mistreatment is physical abuse. So as name indicated, it means that intentional use of physical force may result in bodily injury, physical pain, or impairment. Examples including slapping, hitting, kicking, use physical restraints, or use some weapons to injure the older patient. Sexual abuse means any type of sexual contact with an older adult that is not consensual, or sexual contact with any person incapable of giving consent. Examples including sexual assault, unwanted touching, or indecent exposure. Third one's neglect. It contains intentional or unintentional neglect. It means refusal or failure to fulfill any part of a person's obligation or duties or to an older adult that may result in harm. Examples including withholding of food, life support to the older patient, failure to ensure older adults' personal hygiene, or older adults' personal safety. And it's central. Next one is emotional psychological abuse, which means intentional infliction of anguish, pain, or distress through verbal or nonverbal acts. Examples including verbal berating, harassment, abuse, threats of punishment, isolating older adults from others. Another one is called financial material exploitation, which means illegal or improper use of older adults' money, property, or assets. Examples including stealing money or belongings from older adults, cashing older adults' check without their permission, or force older adults to sign some contract which is against their wishes. Here's another type of mistreatment, which is called intimate partner violence. It can be from a new partner or from a long-term partner related to cognitive impairment or caregiver stress. The prevalence of older adult mistreatment is pretty high. It's up to 10% of communities involving older adults, and also more than 20% of nursing home residents, and also near 50% of low-income older adults. So mistreatment exacerbates chronic illness and depression, and it's also associated with a significantly higher mortality. So that's why we want to focus on it. And as you can see, that the number is also pretty high. As few as 1 in 24 cases are reported to authorities. In terms of risk factors related to the elder mistreatment, so there are two types of risk factors. One's a risk factor to make people become a victim. The other one is risk factors related to a perpetrator. So first one, the first one is risk factors for making people to become a victim, contains these items, including functional dependence or disability, cognitive impairment, poor physical health, mental health, low income, social isolation, previous history of family violence, or previous traumatic event exposure, substance abuse. Well, the risk factors related to the perpetrator includes mental illness, substance abuse, caregiver stress, previous history of family violence, and financial dependence on older adult. So we can see that both risk factors are highly related to the elder mistreatment. However, many cases of elder mistreatment can also occur in the absence of any risk factors. So just keep it in mind. So after knowing that, so shall we regularly screen the elder patient who may suffer from the mistreatment? How can we? So in other words, how can we screen those patients? So do we need to routinely screen those patients? Actually, some organization recommended that, while some organization didn't recommend that. So it's still in debate. But whenever we encounter a patient in our clinic, so as a clinician, we should pay attention to those red flags that may make you think that the patient might be suffering from the mistreatment. For example, if an older adult and caregiver provide conflicting accounts of events, or caregiver interrupts answer for the older adult, or you see the evidence that caregiver and older adult may be abusing alcohol, illicit drugs. These are all red flags that make you think about that. And in terms of medical and social history, when you ask the patient, you suspect that they are suffering from elder mistreatment, you might be. It's better to interview the older adults alone. So, and also you can ask focused follow-up questions. So, for example, you can first ask if there any difficult behavior in the patient's family, or he or she would like to tell you about. And if the answer is positive, you can ask a follow-up question like, has anyone tried to hurt or hate you, or has anyone taken your things? By knowing those answers, you may have a further clue that if the patient is suffering from mistreatment or not. Here we need to pay attention that different racial and ethnic groups define abuse and neglect differently, so cultural sensitivity is also important. And if a patient has dementia, so you should ask the patient the same way as others. If we really have a difficulty to communicate with those patients, we may consider interviewing other families, members, neighbors, or visiting nurses. And also stress, isolation, depression of the caregiver is also relevant to the health of the older adult. So in that case, we may also interview the caregiver, even if he or she is not your patient, and also we can offer some resources to overwhelm or stress the caregivers. And also some caregivers are both well-meaning and abusive, neglectful, which means that if you see a caregiver which seems to be very nice to the patient in the clinic, but still you cannot rule out that if he or she is a perpetrator. So the indicators from the history that raise suspicions of mistreatment include all of these details. Like if you see some unexplained injuries, past history of frequent injuries, or non-compliance with medication appointments, or clinician directions, you may consider this patient is suffering from elder mistreatment. So when you do a physical examination, if you found some bruising in atypical locations, not over bony prominences, but on lateral arms, back, face, ears, or necks, you may think about the patient might be suffering from physical abuse. And also, if you see some patent injuries, like bite marks, bout, buckle, or wrist or ankle lesions, or scars, burns, multiple fractures or bruises of different ages, traumatic alopecia, scalp hematomas, subconjunctiva, or retinal ophthalmic hemorrhage, ophthalmic hemorrhage, intraoral soft tissue injuries. You may also consider about the physical abuse. In terms of sexual abuse, if you see some genital, rectal, or oral trauma or evidence of sexually transmitted disease, you may think about that. And regarding the neglect, it's if you see a patient that has some malnutrition, dehydration, pressure injuries, poor body hygiene, dirty, elongated toenails, poor oral hygiene, we may think about that. So how to distinguish abuse from accidents? So here we have a clue that if you see some bruise from physical abuse, actually were often large and on the face, lateral right arm, or posterior tonsil. And also the abuse-related injuries were most common on the head, neck, and the upper extremities. And also injuries to the left cheek, lygoma, neck, and ulnar forearm. So these are more likely caused by the physical abuse instead of accidents. So here I want to let you know that the location is more important. Is more important compared to other factors. So when sexual abuse is reported or suspected, we may consider sending the patient to the ED for a comprehensive sexual assault evaluation, and also work with the ED personnel to identify those cases. For the labs, if you found a patient has anemia, dehydration, malnutrition, hyperthermia, and rhabdomyolysis, you also need to consider about the physical abuse or any other types of mistreatment. And for the prescription drug levels, if the low level means withholding medication, high level may indicate overdose. And the presence of a toxin or drugs not prescribed risks the potential for poison. So we may consider consulting a local poisons control center. For the image studies, if you find co-occurring old and new fractures with appearance inconsistent with the explanation offered, distal ulnar diaphyseal fractures, small bowel hematomas, we consider about physical abuse, and also consider additional screening, including maxillofacial CT scan and chest X-ray to evaluate for acute and chronic fractures. So the examples of psychological abuse, including threats, taunting, name calling, social isolation for older adult, the signs that warranting a follow-up for potential psychological abuse, including ambivalence toward the caregiver or high levels of anxiety, fearfulness, or anger, uncharacteristic withdrawal, or changes in cognitive function or mood. In terms of financial exploitation, it includes unauthorized use of the older adults' funds, properties, or possessions, and it's often associated with neglect. And here are some potential signs of financial exploitation, like a sudden inability to pay for healthcare or basic needs. You were interested on the part of caregivers in the older adult's assets or unwillingness of a caregiver to allow access to the home of an older adult. If you suspect the patient is suffering from financial exploitation, you can report to Adult Protective Service, aka APS, and potentially also to law enforcement. And here are also some additional resources that you can report to. So the how to prevent the financial victimization. So that in this one we can actually we can proactively discuss appropriate options for financial management with cognitively impaired patients and their families. And also we can refer to neuropsychologists for complex cases as well. And here mentioned about some COVID-19 related to the elder mistreatment. So because COVID-19 it can cause social distancing and stay-at-home restrictions. So this can have an impact, definitely have an impact for older adults. So it can make a because of COVID-19, an older adult may be stuck at home with an abuser and unable to reach out to friends or other people to ask for help. Friends and neighbors may not check in on older adults because of COVID-19 exposure, and because because of fear of COVID-19 exposure. And also home health aides may be unable or unwilling to continue care. And also senior center and house for worship closures can also be a reason that the older adult cannot ask for help from others. COVID-19 may increase financial exploitation because those older adults with stable income can become targets of for family members or other people who need money. And COVID-19 related to scams, so definitely older adults might lose money because of this. And the APS, so the APS had to modify protocols. So in order to conduct fewer home visits and in-person assessment, and for our clinicians, in order to prevent this problem, we can take advantage of a telehealth and strive to assess patients' home environment and talk with caregivers to detect mistreatment early to prevent it. So for the self-neglect, the definition is older adult's health or safety is threatened because he or she doesn't perform essential self-care or refuse assistance with it. So in other words, the older adults doesn't want to take care of themselves, or they are unaware of the importance of taking care of themselves. So examples including not eating, not taking necessary medications, or not maintain a safe home environment and essential. Self-neglecting older adults may not appreciate that their health and safety at risk, as I mentioned. So we should consider that might be caused by the cognitive impairment, depression, psychosis, or substance abuse, or other psychiatric disorders. So how to manage self-neglect? So here we should assess older adults' capacity to understand first, and then keep in mind that the capacity is decision specific. We need to evaluate if the patient can make decisions about healthcare, if they can make financial decisions, or they can determine with whom one associates. When appropriate, the older adults' rights to autonomy and self-determination must be honored, even it's uncomfortable for one clinician. So here we should know that when the relationship between a dependent older adult and the caregivers is functional, so we shouldn't assume that the patient is inevitably the victim. And also the consultation with the social worker, psychologist, or psychiatrist can be useful to determine if there's mistreatment happened for the older adult. Regarding the institutional mistreatment, it's a kind of a risk of mistreatment, and it's higher among institutionalized compared to community dwelling older adults, and it can be aggravated by poor working conditions, low salaries, inadequate staff training, supervision, and disruptive of insulting behavior by the older adult. The same as the rules protect the rights of residents, including prohibiting facilities from forcing residents to arbitrate complaints rather than file a lawsuit. For the interventions, here are some questions we need to consider. How safe is a patient if sent back to the current setting? Do any caregivers have health problems of their own, or should the situation be reported? So here are all questions we should consider to ask. And some factors govern the clinician's cause of action, including exact nature and degree of mistreatment, availability of social workers and case managers. And also we should consider consulting with the health department, and which can be a very useful early step. And the APS can provide information assistance as well. And here are some additional resources we can consider about. In terms of trauma-informed care, it means ongoing abuse or neglect, as well as previous traumatic experience may cause depression, anxiety, or PTSD. So trauma-informed care addresses the patient's need for respect, acceptance, and safety by maximizing patient's choice and control and minimizing additional trauma. And for our clinicians, we should attempt to provide trauma-informed care to victims of elder mistreatment. So after knowing all of those histories and performing those physical exams, and also report those problems to the government or other health professionals, we need to document everything we found, everything we did. So the medical record should be used for investigation, the prosecution. So we need to write a very comprehensive document, the patient's response to questions, the physical examination we did, the injuries we found, and we can also take a picture and use the photograph and physical findings and add it in the patient's medical record. Regarding the medical legal interface, we should know our state law about reporting elder mistreatment, and also the report should be confidential. And the clinical report is protected from litigation, unless it can be proved that the report was made maliciously. So anyway, so this one is let us know that how to report it in the government. Here's the scope of APS duties. So in most states, APS is obligated to respond only to cases in which it is judged that an older adult is functional or cognitively impaired. APS is not a place of force, and it typically has more than 72 hours before being obligated to initiate an investigation. So here's a summary of our of this topic. So we talked about how important we need to identify mistreatment because sometimes for our clinicians we just ignore that, and also mistreatment has a high prevalence, and also we talk about different types of mistreatment, and how to identify the patient who might be suffering from mistreatment, and how to answer questions, perform physical examinations, and to identify those mistreatment. And also we learn how to report those mistreatment to the government, and which department we should report to. So here is a question for this topic. So please take your time to read the question so we can discuss about the answer later. So what's the answer? D. Yeah, this one's pretty easy because remember if you are suspicious that the patient is under its treatment, so the first thing you should do is ask patient history to make sure to identify if the patient is suffering from mistreatment or not. So speak to the patient alone is definitely the first step we need to do. All other options are just related to how to treat the patient who is suffering from mistreatment. So yeah, so this one's pretty easy. Okay, so here's the second question. Please take your time to read it. Okay, what's the answer? The answer C. Yeah, I remember I mentioned location, location, location. So location is the most important factor that help us identify if the injury is caused by physical abuse or accident. So definitely, so the location is the location of the bruise is definitely the first sign to let us know that the patient is suffering from physical abuse. So anyway, so here's the whole topic of this lecture. So do you have any questions for me? Yeah, please feel free to type in the chat box so I can answer it immediately. So if you have no questions, so let's go to the next lecture. Thank you.